Welcome to the noon virtual meeting of the Rotary Club of Baton Rouge. I'm your club president, Mike Manning. It's a pleasure to be with you again. We're on a remote location today. We're doing our virtual meeting from Drusilla Place, where we have underway the quarterly blood drive, and you may hear a few dings in the background from those scales that weigh out the appropriate amount of blood being taken. And you can see that I've already done my part. So we're going to have 30 plus people who are donating, and we're really excited about that. And to look forward as we try to figure out how we're going to come back and come together. We just want to keep in touch, stay in contact, and make sure that we're continuing in the right way as we continue to be respectful of social distancing and all the requirements thereof, but still want to maintain our club, our efforts, and our commitment to the community. With that said, I'll introduce for the invocation Tina Holland, and then Chris Harrell will lead us in the four-way test and the pledge.
Good afternoon. This prayer was shared with me by a Marinist brother, and it's specifically for this time of pandemic and for organizations. So let us pray that hearts, when they are fearful and constricted, may we be granted courage and hope. Where anxiety is infectious and widening, may we be granted peace and assurance. Where impossibilities seem to close every door and window, may we be granted imagination and endurance. Where distrust twists our thinking, may we be granted healing and illumination. Where spirits are daunted and weakened, may we be granted soaring wings and strengthened dreams. All these things we humbly pray, not just for ourselves, but also for our Rotary Club of Baton Rouge. We pray, amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Of the things we think, say, and do, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Thank you, Tina and Chris. Before moving on to our introduction of our speaker, I want to remind everybody that we will again have another virtual meeting next Wednesday, and we'll have Chip Klein to talk to us, give us an update on the BP oil spill and where all of that is and what the recovery of that looks like. With that said, I now introduce past President Stephen Winkler, who will introduce our program.
Thank you, Mike. Of course, today you'll notice I'm in my best Cajun PPE just for this occasion. But before I introduce the speakers today, I wanted to explain to you why so many people say that testing for the coronavirus was so painful. Most people think it's this little swab that you see on the side, but the reality is that it's actually this size, and that's why it is so painful for folks to have that test done. It is indeed my pleasure to introduce today two distinguished speakers. Rebecca Christopherson is the assistant professor in the Department of Pathological Sciences at LSU School of Veterinary Medicine in Baton Rouge. She graduated from the LSU College of Science with a BS in zoology and the College of Agriculture with a master's of applied statistics. She then went on to receive her PhD from LSU School of Veterinary Medicine, focusing on infectious disease transmission, especially mosquito-borne viruses. She studied the processes that lead to outbreaks, that promote or hinder control, and that predict persistence, emergence, or expansion of these pathogens. She lives here in Baton Rouge, having grown up here and attended St. Joseph's Academy. Dr. Beverly Ogden, our second speaker, is a New Orleans native and is the medical director of laboratory and research at Women's Hospital, as well as the River Road Testing Laboratory at the LSU School of Veterinary Medicine. She received her Doctor of Medicine degree from Tulane Medical School completed her pathology residency in New Orleans at Touro Infirmary, Tulane, and Oxford Medical Foundation, and has been practicing medicine here in Baton Rouge since 1987. She is board certified in anatomical and clinical pathology. Ladies and gentlemen, I introduce Dr. Christofferson and Dr. Ogden. Thank you very much.
Thank you all for having us. It's good to be here. So we kind of have a little agenda where we're going to start out with how this all started, and then we'll kind of go back and forth. We'd love to have questions at the end or during if you have a burning question for us. I'm Rebecca, in case you didn't know. So this all started really, so I study emerging viruses. So I kind of had my eye on this virus really when it popped up in December, just because when new viruses pop up, that's what I'm interested in. So I was watching it, and I have some messages to friends that didn't age well. Oh, this is just like the flu; it's gonna be fine. And then I actually went to I was in France from the end of January through the beginning of March. I was a visiting scientist at the Pasteur Institute, and I was doing some modeling on disease transmission. And about the middle of February, all things turned into COVID. Everything was it didn't have a name at that time, or had just gotten a name. And so by then it was sort of creeping into Europe. There was some concern about Italy was starting to get pretty hot. And at that point, we knew that it was just a matter of time that this thing was spreading so efficiently that it was going to get to the US. So I got back to the US on March 6th. And by March 13th, we were in talks with the area hospitals and physicians and Dr. Ogden. Me and myself and my partner in crime, who couldn't be here today, Dr. Stefania Cormier. We originally were talking about just making viral transport media. One of the things we ran into quite quickly was that there was a shortage in testing kits, which is the actual swab and the liquid in the tube that's needed to sort of preserve the sample. So that was kind of what we dove into right off the bat. Stefania is an expert in respiratory viruses and respiratory infections, and so that was her forte. But then quite quickly we started talking about what's going to happen next. And on March 9th, we had the first presumptive case in Louisiana. I had a pretty good idea that was not the first case at all. It was just the first one we saw. And then I think it was March 17th or thereabouts where we had the first presumptive death. Around the 13th or 15th, I shouldn't say. About the beginning of March is when we really started to look at the difference between what was happening in China and what was happening in Italy, because those are really different populations when it comes to the age structure, when it comes to comorbidities and lifestyle. And so we started to really notice that we had these comorbidities or these pre-existing conditions pop up that was making a certain portion of the population have severe outcomes or death from COVID. And those outcomes those comorbidities were hypertension and diabetes. And if you're from Louisiana, you know what we eat really well here. And so we have a high rate of both of those conditions. So at that point, I had a feeling that our at-risk population was going to be bigger than maybe we had seen in Wuhan. And so I was concerned that the stress on the healthcare system was going to be underestimated if we kept looking at Wuhan, or even if we kept looking at the beginning of the data for Italy on the assumptions of what this outbreak might look like. So we got together with several of the hospitals in town, and we said we could do PCR because we do it on a regular basis, and that's something that we do pretty much every day. We do high throughput PCR because we have a lot of mosquitoes here, so we do a lot of stuff with mosquitoes. So Steph and I and Dr. O'Neill and Dr. Ogden and the Baton Rouge General and Our Lady Lake and Women's, we all just got together and decided this is a thing we're going to do. And I'll throw it over to Bev, but it was a big learning curve going from what I'm used to, which is an academic research lab where you do things in a pretty controlled manner, to a clinical lab, which is just like fun chaos all the time. So.
Okay, so while you were doing all that wonderful thinking about planning for the virus, we in the hospitals were panicking because at that time, once the first case was here in Louisiana, we wanted to say, how will we be able to test for this? And so we all scrambled to see, to test, you have to have equipment. So we all looked at the equipment that we already had in our hospitals and started calling the companies. And we heard from the companies saying, oh, we're not going to have anything till May or June. And so we were like, this is going to be horrible for us. And we even at Women's, we have a molecular biology lab. We had 6 types of equipment that we could do testing on, and it still was predicted in May. So when I was looking, my CEO told me that they heard LSU was looking into testing. And so I gave Becky's lab a call and said, would y'all mind doing some testing for us? And they said, well, yes, but by the way, we need a medical director. I said, okay, so some stars are starting to align here since I can be a medical director. But Becky's right, just because you can do a test doesn't mean you can test humans. And there are regulatory agencies. The biggest one is CLIA. It's Clinical Laboratory Improvement Amendments. It's been there since 1988, and it services the state. It's a licensure for the state and also allows us to test Medicaid and Medicare patients. So no lab can do a test on a human without meeting the requirements and becoming certified by this agency. So fortunately, another star aligned for me because I'm on a committee with the manager of CLIA. And so we called her on Saturday. We started working this on Saturday, March 21st. And we called her and she helped walk us through the steps because this is usually something that takes 6 months. And we certainly didn't have 6 months to get this started. So she walked us through the steps, and it is very labor intensive. Just because you can do a test, you have to prove you're reproducible. So the things we had to start doing, poor Becky and her team had to start working and meeting all the requirements. What you have to do, you have to prove you can do the test. So you have to find some lab that has had positive and negative tests on patients and prove you can mimic that. And you can take those samples and do those tests and get the same results. Well, the only test lab in the state that was testing was the state lab, and they were doing 250 tests a day. They were backlogged. They were maybe taking 5 days to get test results out. So Dr. O'Neill, who's an intensivist at Our the Lake LSU, he was the partner that Becky talked about. He actually went and collected specimens on patients in the ICU and gave assessment to the state and to us so that we could compare them. So we're able to compare those to say, yes, the state got a positive result, we got a positive result, but it doesn't stop there. Becky said, we made our own media at LSU. Well, in the real world of laboratory tests, manufacturers take years to say, this is a good media, it doesn't have any interference. So we don't have years to prove that this media is good. So we had to take the media that the LSU Vet School so wonderfully made for us, and we had to prove that that was accurate. So we had to compare it to manufactured media to say that that was it. Also, we had to prove, just because we do the test, we had to tell them, well, how low of a virus detection can you get? So we had to dilute out samples and prove, well, this is how low we can go. And CLIA says, well, that's true. You have to prove you can do it 20 times. So poor Becky's out there trying to do that 20 times. And after that, you have to prove not only the test is good, the people doing the test are good. So that's called compliance. So everyone doing the test had to do a fair number of tests to prove that they could pass. And then you had to prove something called precision. And it means that the same person could do the same thing 3 times in one day and do it another day on a separate day 3 times and get the same results. You also have to prove that your test, because this is not a test, this is not approved by the FDA. This is a test that Becky and her team was able to put together and make work. But the FDA usually says, well, you've got to prove. The FDA usually says, usually I get a test kit that says, this has been worked on for 2 years, and now the FDA has said, this is a perfect test. Well, right now, nobody has proved this test. So we had to go to the FDA and say, we think we can do this test. So this was all very surreal to be able to do something in 48 hours that usually takes 6 months to 2 years to do. But we did run it. So the CLIA was very helpful. So we were able to do all these things, Becky and her team up all night, running machines, all that other stuff. And then we had to say, well, yes, our lab can do the test properly. But the state, Louisiana State Board of Medical Examiners said people who do laboratory tests have to be licensed in the state to perform a test. Like, okay, here's another barrier. And unfortunately, I am on the committee. This is another star aligned. I'm on the committee for licensure for laboratory people. So I had some emails. This is a Saturday. I started emailing them and saying, look, this is what we're doing. How can you help us get this done? Not helpful. They gave me some contacts. I never got emails back. Nobody would respond. This is 4 o'clock on Monday. We're ready to test. Becky has done everything she's had to do and her team. We're ready to start testing, and we can't get our personnel licensed in the state. So I started emailing Dr. Cormier and I started emailing everybody, the governor, the senator, the CEOs of every hospital, everyone who test, like, we're ready to test. We know no one can help these hospitals but us. So we emailed everybody, and I finally got a call back from the director of the Louisiana State Board of Medical Examiner, and he said, Beverly, here's my phone number. Here's my fax number. Please don't talk to the whole world when you have a question for me. I didn't know because no one had called me back. So I have every email and phone number for him. But he said the governor on Saturday had waived the licensure. So at that point, we were ready to go and we're ready to start up. But so without their team, like I told you before, nothing was available to us till May. So we started May 21st, and we didn't even have any other testing in our state, in our city, until probably April 20th. So it would have been that amount of time that no testing would have been done. And what Becky's team was able to do, they tested 3,857 patients during that time. And I think, Becky, you pipetted every one of those, I think, in the bio-level safety room. Our positive rate, so out of 3,857 samples that a River Road testing lab did during this time, we had a 33% positive rate. Our age range was from an NICU baby to someone 99 years old. We had 14 moms, pregnant moms, that actually delivered, and 4 of them were very sick in the ICU during this time. 1 actually died from COVID. Right now, we have about 20 women who are pregnant that haven't delivered yet that have it as well. So the service that this laboratory provided for our community, it'd be very hard for us to pay them back for what they did, because we would have been, and Becky, I think after this, you can talk about how much money this saved patients. But when we started testing and we started calling those first results to the lake and the general, just whether it was positive or negative, the morale of the whole hospitals changed because they had no idea. Every person that had a fever, they had to treat them like they had COVID. People who have COPD, chronic obstructive pulmonary disease, sometimes they have fever. And anyone with that, they still had to treat them like COVID, isolate them. And initially, you couldn't treat COVID patients with steroids, and people with COPD need steroids. People who see COPD also need breathing treatments, and you could not give COVID patients breathing treatments. So the personnel in the hospitals, the staff was there. They were very frustrated because they couldn't take care of patients the way they wanted to, and they didn't know what their other patients had. So when we called with those results, after Becky's team was able to give them, the morale of the whole community changed because at least they knew what they were dealing with. They could isolate patients and they were able to save money. We tried not to advertise what we were doing because we were just getting started and we wanted to make sure we were doing everything and we wouldn't exhaust Becky's team. But we ended up, the word got out, and it really was funny because Dr. O'Neill and I would get phone calls because I guess people found out about it. It was really like a drug deal. Someone would say, how many tests can you do? How many can you do? And it really felt like everybody's on the phone dealing. And it really is like a drug deal because people would show up to the vet school with a white box with specimens in it, and we would give them a white box with collection kits in it. But we ended up, these are the people we serve. We did the Baton Rouge General, Our Lady of the Lake, Women's Hospital, Lane Regional, Lake Charles Memorial. They drove 2 hours both ways each time to bring us specimens because they had no other way to test. St. Tammany Parish Hospital drove 2 hours to get to us. Point Capee Hospital, West Feliciana, Promise Hospital. We did several nursing homes that had no available testing. All the symptomatic EMS workers and symptomatic healthcare workers in hospitals had no place to be tested. So we provided that as well. We provided for the Baton Rouge Clinic and the East Baton Rouge Parish Prison. So during this time with all this testing, this is a community service that this lab was able to provide because Becky and Dr. Cormier had this idea to be prepared and help us in our community be prepared for something that they knew was coming and was going to be very significant for us. And without them, and we were lucky to have them in Baton Rouge, to have them at LSU. And I think we as a hospital are, we're a small medical community. We cannot pay them back enough to thank them for what they've done for our community.
Yeah, so I want to give a shout out to the team. So Dr. Cormier was, she's just a firecracker, and we're both actually from around the Opelousas area. She's from Lewisburg/Church Point. So it was fun to work together there, and just we really wanted to help the community because we kind of, or at least, we had an idea that this was not going to be good. And it was an amazing opportunity. And I have to say, I'm going to give a shout out to the people who worked with us because I'm so proud of them. They all stepped up. It was all voluntary. No one got paid to do this. We worked anywhere from 12 to sometimes 20 hours a day, every single day. Our first day off was Easter Sunday from March 24th something, 21st. And so there's pictures of us sleeping under desks. So we had in the BSL-3, so we did this in the vet school has a high containment lab, and I'm a high containment virologist. So we did it in the high containment lab because it just afforded us a little bit of extra protection, and because one of the things we really had to sort of work with was a diagnostic lab is set up very differently from an academic lab. And so we had to sort of engineer our working spaces to sort of have this sort of flow that you need to ensure that everything's done more efficiently and just the way that it's supposed to be done. So in the BSL-3, there was myself, my senior graduate student, Hanley Mayton, and the biosafety manager at LSU, Dr. Abby Fish, who just volunteered. Like, she's not even in my lab, and she volunteered, and we really couldn't have done it without her. And then the PCR team we had was Dr. Cormier, her postdoc, Luan Vin, Thea Guidry, who's a research associate at the vet school, and then we had admin support of my other graduate student, Chrissy Walsh, Dr. Cormier's research associate, An Fan, who is just an amazingly calm person through all this chaos. Like, she really kind of held it together. And then my grad student who joined my lab approximately 2 weeks before all this started, Eric Turner. So I'm sure he's questioning some life decisions. And then the lake actually and the hospital supplied people to do the data entry, to do the accessioning. So we had a resident, Morgan Walker. We had a couple of doctors work with us, John Schroeder, Bud O'Neill. So we had physicians come in and really help. And the accessioning took a lot of time that I was not prepared to understand. We had several data people come from both the lake and Baton Rouge General, and I think Baton Rouge Clinic. And we just also had a lot of support from, Baton Rouge community. And it really was it was a really sort of refreshing community effort all the way through. And it was something that I'm very proud to have been part of. And I'm super proud of my people having been a part of. So yeah, we don't need any payback. There are people too.
But Becky, I think everybody wants to know, what about this virus? What can you tell us with your expertise? What do we know about this virus and what we don't know?
So the good news is like we've been saying, washing your hands really does kill the virus. And that's because I saw it explained somewhere that it's basically a bunch of genetic material surrounded by a bag of grease. If you've ever seen a Dawn commercial where they put the Dawn and the grease busts up, that's basically what washing your hands does. It's probably scary because we can't see it, right? So the reason that it's going off more than the flu is because so many people are either asymptomatic, meaning they have zero symptoms, or what we call subclinical, which means they might feel off and say, oh, I got allergies or whatever, and they actually can be transmitting. The other reason that we kind of tout that it's not like the seasonal flu is that the seasonal flu has some immune pressure. So when you take a vaccine and you give it to even a subset of the population, you make that subset unavailable for infection. And so that sort of breaks up the possibility. It's like a giant pothole in a bridge. You can't get over it because that person is immune. So when you have something like this where no vaccine is available and everyone is susceptible because it's a new virus, basically all the roads are open and there's no traffic. It can just go. And so that's why it's just taken off like it is. We don't know what the seroprevalence is. Baton Rouge General has done some wonderful preliminary work on antibody testing, but without like a really scientifically a randomized controlled kind of giant undertaking to really get at seroprevalence. We don't know how many people have been exposed. The other problem is we really don't know if being exposed means you're immune. Some respiratory viruses, you will develop an antibody test, which is what these tests are looking for. But that doesn't necessarily mean that you're immune. And so it could protect you from severe disease, which may be enough, but we just don't know. And I understand that it's frustrating, but for example, I've been studying some of my viruses for 12 years, and we've been studying COVID as a giant scientific community for about 6 months. So we ask a little patience there. Kind of going off what Beg said about the drug deal thing is like science right now really is working. I tell people like a bunch of old ladies from Krotz Springs. It's through telephone calls, it's through emails. It's like this network. When you tell, one aunt who lives in Cross Springs what's going on, or then the other aunt in Opelousas is going to know what's going on, and it just goes straight down, Airline Highway until it gets everywhere. So, so it's a very interesting time to be in science. The other thing is trying to separate the operational support of science from the research. And so those are two very different things. For example, in research, when we get a positive, we're like, ooh, yay, we got a positive. And it was an interesting turn of mindset that in clinical diagnosis, the negatives were important, because those were the people you could move out of the COVID unit and not have take up resources. And so like Bev was saying, because we had a quick turnaround time of anywhere from 1 to 3 days, it was usually between 24 and 36 hours that we could get results out. But anywhere between 1 and 3 days. The state lab is responsible for the entire state, and they have been working tirelessly. And so their turnaround time is not quite as fast, just because they've got just a large catchment that they're responsible for. And then the commercial labs are the same way. Their turnaround times were a little bit longer. So just by being able to sort of speed up the time in which we could give results, one preliminary calculation that I've done is we've saved tens of thousands of sets of PPE. So the masks, the gowns, the gloves, those sorts of things, which enable patient care, not only then, but going forward as we try and see what's going to happen as we open up. So
I was going to say, Becky, for us, what was more frustrating, you said that testing capacity, when this first started, the government decided they wanted everything to be centralized. So they came at their LabCorp and Quest are the places where to send your test. So before River Road Testing Lab started, we had to look into contracting with them. And LabCorp, when they said that on the news, LabCorp only had one facility in the whole country that could test, and they only had a capacity of 2,400 patients a day, and they were getting 10,000 patients a day. The other lab, Quest, would not even quote how many tests they were getting, and they wouldn't even quote their turnaround time. Women's had to contract with LabCorp because River Road Testing Lab wasn't up when we first started. When we first knew about this, our turnaround time from LabCorp was over 14 days, which is clinically irrelevant at that point. The patients in the hospital, they've either survived or they've gone home, but that was clinically irrelevant at that time. So one of the biggest lessons that I've been the most complaining about to everyone I can complain about is centralization was not the way to go. Every lab in this city, we each had maybe a total of 10 machines that we could have done testing on. So decentralization would have been the way to do it. But what they did is they told all the manufacturers of the companies that we use, and we're big users of some of these companies, they told them you need to send all your equipment centrally to the Department of Defense so that they could get it to the LabCorp and Quest. They did not decentralize. So we are still fighting that battle. And I've been very disillusioned because we've had to fight every inch of the way to get testing in-house still. And so today they're even telling us, we can't guarantee we're going to keep giving you tests because we're told to send it to the national government. So we have got to change that cycle, get it into the communities where it's needed. Because you have to ship it. First of all, to get it to LabCorp has to be shipped overnight. And how do you know that the media that it's in is going to survive? And that it's not the best way to do it. So we're still fighting that battle, and hope we've learned that battle. But until we can do that, we can't really test high capacity. Becky mentioned that the Baton Rouge General was doing some antibody testing around the state. I'm on a committee that does statewide. We talk about the statewide tests. Like Becky said, everybody's networking, which is great. Now, Oxnard and in Shreveport and Baton Rouge General too, they've looked at the people who are the most exposed, like healthcare workers taking care of the sickest patients. And with these antibody tests, they're actually finding it's very low. And so the highest that Shreveport got was 9%. In New Orleans, I think they're seeing 5%. So even though the healthcare workers that are being exposed, we're not seeing a lot of antibody production. That's one good thing. Probably the PP is working. These people are using proper protection, but we haven't even gone into the community because, like Becky said, there are some asymptomatic people, and we've started testing some pre-op patients. So to get patients back safely into the hospital now, we're testing everybody. At Women's, we're testing everybody who has surgery and every OB patient. We also provide some testing for the Baton Rouge Clinic. We've continued some of that we started at River Road Testing Lab. And we do have a handful of people that never know they have it and they're positive. So until we don't have the capacity to do that massive screening to see how much is in there, but we really do think there's a large number of asymptomatic people out there. And that's why Becky says you have to be safe. You have to pretend like you don't know you don't have it because you may have it and you don't know. Wear your mask, wash your hands, stay away from everybody, and be safe. So for us, I think that, like Becky said, this has been a great experience for us as a hospital. Again, it was nice to see the community hospitals, which sometimes they can be adversarial, but there was no adversity what was going on. The Baton Rouge General, the Lake, the Baton Rouge General bought a $47,000 robot to help Becky's lab do the test. Scott Wester, the head of the CEO of Our Lady of the Lake, actually paid for our CLIA license with his Visa card. So I mean, everybody was working together, and that was really nice to see. And I think we're lucky in our community to have the resources we have and the people that stepped up to help us get us where we are. So we don't want to let this sort of atmosphere go away. I think this relationship with the virologist here, we're lucky. Everybody thinks everything happens at a medical center like LSU, New Orleans, and Tulane. That's where everything's happening. We're lucky to have these resources in Baton Rouge, these experts in our backyard that we can partner with the private and academic sector. So we've already started amazing research with the things we've had. We're looking at the vertical transmission from the mom to the baby. We're looking at these antibodies. Becky and the lab at LSU is trying to find, are antibodies being made that are immunoprotective? Like Becky said, you can make an antibody, but doesn't mean it's going to protect you. And so I think LSU, and with this team, we're working on ourselves to find out whether there is immunoprotection. So I think with the patient population that we've been exposed to and have the privilege to test, we are going to be able to do some amazing research, and we hope to continue this relationship.
Absolutely.
Do y'all have any questions?
Yeah, we'd love to open it up for questions.
So the first question was, you mentioned PCR. What is PCR?
Yes.
That was Lisa Stansbury's question.
Yeah, so sorry, we get caught up in acronyms sometimes. PCR stands for polymerase chain reaction. And so basically what the test, that the viral test is, now this is not the antibody test, but the viral test, it says that you have a piece of the virus genome in your nasal pharyngeal swab or your whatever sample it is. And the test that you put in detects it and then makes more of it. And that amplification tells you yes, no, it's in there. And then it can also tell you how much is in there. For the CDC, it didn't really matter. It was yes, it's a yes, no question for a diagnostic test. But for virologists, we're interested sometimes in how much virus do you have and does that make a difference with how sick you get. We're not really seeing that in a preliminary kind of way. And other labs are not really seeing that either. But yeah, so PCR is the way that you detect virus in a sample.
Okay. And so Shard Reshard asked, how many tests was River Road Lab able to run on a daily basis? And then also Bobby Carey wants to know, and so how many have you done to date total, and how many can you do in going forward now per day?
So we usually did 95 per day. There were a handful of days where about the peak where we did twice that, so it's 190. Each 96 that we did would take about 6 hours. So we would overlap that. So to run two would still take us about 12 hours. So that was how much. So we've done just at 3,800 tests, I think, to date is what we had.
Yes.
Yeah, and we were never meant to be a long-term lab, so we are actually stopping our because when LSU opens up, the lab that I occupy is a shared lab, and the other reason we were really able to do this was because everything was on lockdown, and the lab space was empty. So we are going back to operations where we're having other people occupy that lab space. So we're kind of toning down. We were always meant to be a Band-Aid. So we were originally supposed to stop April 25th, and the hospitals were like, we're not up yet. Can you keep going? And we're like, yeah, we'll go to like May 1st. And then May 1st came on, and they're like, So we went, and I think our last official day was May 15th.
So we have a couple of questions about the same thing.
The hospital did pick up testing, but
Yes.
and not every hospital has high capacity tests. We're able to do about 120, maybe 150 today at Women's, but that is a toll on the people. Just because you can do that many tests, the machine can do it. We only have 2.5 people that can do the test at Women's. At Becky's lab, there were 4 people doing these tests all the time. So doing it 7 days a week, even though there's testing capacity, doesn't mean you can continue to do that. So it is hard to keep at that high level because we're just a hospital. We don't have extra staff that's doing it. We're using the staff we're doing. Like Becky said, registration. She didn't realize how hard it is. We have 5 people every day on registration to get these through. And so Becky's team was making it work. So it is a labored effort. So I think in town and Women's, we were trying to promise Becky that we would get up soon enough to give them a rest, but we weren't able to get up. They still had to stay on board, but we have been able to. So everyone, the facility that was being taken care of by River Road Testing Lab is either taken by us at Women's or the hospitals are taking care of themselves. So we have absorbed what good work we were doing already at River Road Testing Lab. We didn't leave anybody out in the cold.
Okay, we have a couple of more questions. What is the average turnaround for lab results now? And Laura Lindsay, especially at places like the LabCorp.
Well, LabCorp and Quest and also Mayo Clinic, that's some things that we send to the community, a minimum of 72 hours. It depends on what happens, like Mayo's computer crashed one day, so they were down for 5 days. LabCorp's computer crashed as well, so minimum of 72 hours. So just like Becky, if you do it locally, like if we get a specimen in the morning, we run it that day. It may be ready by noon. It may be ready by 2 o'clock. So usually 24 hours now. If you keep it locally, it's about a 24-hour turnaround time, just like Becky was able to do.
Okay, and Laura Thomas is asking, what are your thoughts on a possible second and or worse wave of this virus?
Yeah, I'm expecting a second wave. You're going to have an uptick in cases as you open up, no matter what. From what I've seen, there was no phasing. Everyone went straight to Black Friday shopping around where I live. So I expect there will be a second wave. I hope that it won't be as bad. I hope. I kind of think it will be as bad. My other problem, and we can kind of go back to this, was even when we were early March, there were really 3, maybe 4 hotspots in the United States: New York City, Louisiana, Baton Rouge, New Orleans, and Washington State. And at that point, we had supply chain issues. We had to get U.S. senators involved. We had to yell at regional CEOs or whatever of major corporations. And I don't think they were prepared to deal with 2 mad Cajun women, let me just tell you. So we, supply chain is worrisome, as not only will maybe Louisiana have a second, possibly worse wave, but the rest of the country hasn't had really a first wave. And so as everything kind of goes back and people start going, congregating again, it's going to be a culmination not only of us having a second wave, but as the rest of the country lighting up at the same time. And at that point, the centralization of testing, like Bev was talking about, will become an issue, because how do you prioritize that?
And Becky, even when you were doing the test, like you had thought ahead to order a bunch of tests. You had 10,000 tests you could do, but one part of your test, your plates, actually, they said they were going to ship to you, and they ended up not shipping to you because they said, oh, University of Tennessee and New York are now up and running. So then you were competing with other people. So we are not in a good supply place right now. Companies are already telling us that they can't guarantee, like we've ordered 3,000 tests ahead of time. They are guaranteeing they can do it. They send us a box of controls, which usually has a full box. They send us a third of it in the box. People are rationing stuff right now. We are not prepared for a continued thing or even an increased thing from a supply chain. And again, trying to centralize this stuff, and the government is still trying to get, we asked for something that we were back ordered on, and they told us we had to call FEMA instead of a company who we usually deal with on a day-to-day basis to supply our normal supplies. I want to bring up another thing. During this time we were testing at River Road Testing, we had a few children. The youngest was 3 months old. We had up to an 11-year-old. The children were doing fine, and some of them actually had double infections with other viruses. But now that more and more children are getting exposed and infected, we're seeing that there's this autoimmune syndrome that is very significant. So that's the problem with it becoming more and more widespread. Everything's, oh, children are fine, people who are well are fine. When you make it more widespread, initially you see all the people who are very sick and susceptible that ended up in the hospital. You get a widespread thing. You're going to see more people that weren't in that category having problems with this thing. And the children are a prime example. So usually the children handle fine, but you get enough numbers in there, you're going to have these children that have these autoimmune problems that are going to have very significant disease, and it could even be fatal.
We had this similar with Zika. When Zika blew up in South America, I had been studying Zika, and we really hadn't associated with like the microcephaly, which is the malformation of the children's brains and skulls. And the way I explain it is 1% of 100 is one person. And that maybe you don't see that, but 1% of 1,000,000 is a lot of people. And so there's a lot of people saying, well, it's got the same case fatality rate of the flu. Perhaps, but 0.3% of 100, you may or may not get one person. 0.3% of 1,000,000 is a lot of people. And so it's not really about, percentages can be misleading when you're not really thinking about the denominator, which is the total number of people affected.
Okay, we have several more questions. Another question, this is from Karen Profita. Do you know of any other universities and or hospital partnerships that have been doing what you guys have been doing?
I know several clinical labs have begun. I think we were the first. I keep looking on the FDA for them to list our EAU or EUA. I know Yale, a friend of mine at Yale, started doing testing, but it was research use only. I think they're now partnering with the hospital up there. A friend of mine at George Washington University started or tried to start. They weren't quite, their hospital didn't work quite as nicely as our hospital, but that's because we're from the South. And but they did do some partnerships with them, and then I think he was doing some testing for maybe Department of Defense or something. There are labs at the University of Florida, Arizona State University. So now, yes, there are a lot of labs, I think, who have begun to do this. But I want to say that we were probably in the first 2, 3 that really got it going.
You may be the only vet school, though. I got calls from around the country saying, we have a vet school in Oregon. I got a call from Oregon. We have a vet school here. How can we do it? I said, oh, my goodness. You got to have the right people.
We've gotten a lot of calls, too, saying, like, how do we do this? And I'm like, I don't know, ask Bev, because I was half asleep the whole time.
But you have to have the virologists. Without the experts, they had to invent this test. You know, even for right now, the FDA says, this machine isn't made for that test. This machine is made for a virus. You can tell a virus, but if you want to look for a specific virus, it's all up to you. And so with them, without their expertise, we wouldn't have even got started. And even with us getting started at Woman's, the same thing is we have companies and they weren't saying, here's a prepaid kit. This is saying we're a company. We can test for a virus like the companies we use. They test for herpes and group B strep. We can test for those. If you want to test it for something else, you're on your own. And so actually the experience from Becky and Dr. Cormier helped us get our tests up and running because we had to do an FDA because we were early as well. We had to do an FDA EUA. Now companies are coming out and say, here's our FDA EUA, do my stuff, but not until recently before. So without Becky's expertise, we would not, and Dr. Cormier's, we would not have been able to bring testing up at Women's Hospital before these companies had a full-blown test ready.
So Short Reshort is asking, can you talk about the sensitivity and or accuracy of the rapid test, the ID test and ID Now test compared to the more traditional testing methods?
Well, I can talk about that quickly, Becky, because the state, everybody wanted that fast test. And what Becky said was about the PCR. Like when you have a little bit of something, the way you can detect it is you have to copy it until you can see it because it's so little, you have to copy it. So to do that many copies, which we call 40 cycles, that's what you have to do to really do this test right. That takes about 2 hours. So you can imagine if a test takes 15 minutes, how much of that multiplication is it going to do? So the company, there were a lot of bragging companies out there. I could really write a book on my aggravation with companies. But anyway, so the company out there said, oh, we can do this Abbott ID Now. And you know how many test kits, when they got on the news, they said that they only had 50,000 tests that they had available. So they got on the big advertisement and said that. And so one bad thing about the FDA being so nice, like the FDA says, tell us you're doing it and we'll register that. You have 2 weeks to prove that you're doing a good job. What they found out is they approved some of these companies doing something and they look back now and maybe there were some problems. With that test, the state, they started giving those tests away. The company would give it to states and they started handing them out. So every hospital, we got one and we were already doing other testing. So, okay, well, maybe this would be good to do the rapid test. We could never get that test to be positive because you have to have a very strong positive viral load because you don't have to copy it. You don't have to copy it too much if it's already there to see. If you have to copy it a lot to find it, which we take 40 cycles, 2 hours to do it, that machine is missing it. And since then, and the FDA didn't have a lot of time for that company to take 2 years and prove this test is good, right? They just rapidly put it out there. Now, the FDA has come back to them and said, you cannot issue a negative test. It is out there. The company had to resend it and call all of us and say, You can only say presumptive negative, and if it's negative, you have to do another test to prove it. So that was one of the bad rapid things. So that test can have up to a 50% false negative rate. And the problem with that is I heard the White House had a case, and the White House that's what they used every day. And so someone was positive, like, oh, that person was really positive. And then they tested the president and other people in the White House and go, they could have a false negative. That is not a good test to be testing the White House with. You need a better test. So rapid tests like that got a big profile, but they are not, we gave our kit back, and people aren't using it as much anymore because it doesn't have as much meaning. Unless you're in a really sick person you think has a high viral load, you may get a positive test. But
Okay, so another question, this is from Judith Roberson. Some people are saying masks are not effective. Can you share why they are, or how long do we think we need to wear the mask to protect ourselves? And
So I know the mask thing has been very controversial, because at first it was like, don't wear the mask, and then it was, well, now we have to wear the mask. And again, I would say that's because we're still learning about this virus, and we're still trying to figure out everything we really know about this virus is in the context of other coronaviruses, which are relatively mild. So all that to say that the mask is there to protect other people. So if you have a virus, right, and you sneeze or you cough or you're a person who spits when they talk, then you can see we're having a barrier. Just a barrier would protect somebody who's not 6 feet from you, because the recommendation is 6 feet or a mask. And so if you can't maintain 6 feet, the mask is there to sort of create a barrier between whatever you're spitting out or sneezing or whatever and the person who can't maintain that distance. So we wear masks. I have masks for everybody in my house, and it's basically there to protect other people.
well, we had in our lab, we have 100 people in our lab, and in lab like Becky's, it's a large lab, but we have a closed environment. We have people who do blood banking together, and maybe 4 people are sitting right next to each other. We have other labs where people are sitting next to each other. We've always worn masks, and we've had 2 people that have turned up positive, not from exposure to the hospital, from personal experience. So we had to watch everyone who was close contact with them, and no one got exposed. And this was very close contact. So they found that with healthcare workers, everybody thought, oh, a lot of these positive people are going to be healthcare workers around there. They're not. The infections are coming from people at home. And so I think that's where, we're wearing the mask, and even sitting right next to someone for a week in close quarters who was talking, doing other things, it was not transmitted. But at home, the biggest exposure is a home-to-home transmission, adult to adult, 17% transmission.
And that appears to be the end of the questions. Do you have any closing comments?
Just that, I'm a biologist and epidemiologist and whatever. I'm a science mutt, basically. And there's a lot of controversy about shutdown versus opening up again. And I have this conversation often. And, the easy thing to say from a biology standpoint is shut everything down. Shut everything down for 2 weeks. It'll go away. But we as biologists and epidemiologists understand that this is not a biology problem just by itself, right? There's the economy, there's people's mental health and everything. And we are going to have to figure out how to live with this thing coming up, because it's not going to go away in a couple of weeks. It's not going to go away in a couple of months. We are due, I think, for a second wave. And so for me, for example, I miss hugging my daddy. I miss hugging my mama, so we're going to have to figure out how to live with it in a way that's going to minimize our risk and our risk to other people. And the guidelines are going to be fluid. It's going to be changing as we learn more and more. And I would urge people to help us scientists communicate, because sometimes we're kind of bad at that, but help us communicate that we're still learning. And it's not that we're trying to mislead anyone. It's just that we're just still trying to figure it out. And there are lots of people the world over who are working really, really hard and long hours, doing a lot of different things to try and figure out what we can do better to live with this virus. And so we as sort of, somewhat socially awkward people really need allies in the community to say, I know wearing a mask is uncomfortable, but it's a small price to pay. Or yeah, I know they said that one thing and they said this other thing, but like maybe they just learned something new and they're sharing it now. So as we really do need the community like you to be allies for us in science, and especially as we go forward with how to live with this thing. So
I agree, Dak. And I think just being smart, I mean, it's not like you have to totally isolate, but getting into a room with 100 people is probably not a smart idea. And, you know, just not even spitting when you talk, but just talking. So distance, I think the basic stuff that everybody's saying is smart. And it's not that hard to do, really. And I think wearing a mask, keeping a distance, washing hands, that seems to be simple. And I think we all stick together with that. I'm very optimistic that we could take care of the situation ourselves, but not allowing it to spread. So I agree. I think we need to be optimistic. I think don't get depressed because you can't do the normal stuff, but get out and do things in a reasonable way. Try to get back to a normal life, but be reasonable. Don't throw caution to the wind and say, oh, I'm not worried about it because I don't know anybody that has it. Because when we start testing, you're going to find out you're going to know somebody who has it. So just be safe and be smart, but get outside, be healthy, and do what you can. But we appreciate the opportunity to speak to you all.
Well, thank you both, doctors, for really bringing the realities of the situation to us and cutting through all the misinformation that's out there. We truly appreciate it and appreciate you taking the time to visit with us.
thank you.
Okay, next Wednesday, we'll be back again for another virtual meeting of the Rotary Club of Baton Rouge. Chip Klein with the BP oil spill update will be with us. Look forward to seeing you all then. Take care.